Everybody. I think today's session is going to be very interesting, and it is the very basic steps in ICU. I can say for the nurses, the oxygen therapy in the ICU, which is very important. Most of the times it is forgotten, but I think it is one of the very important aspect of critical care medicine. And with to add this topic, I think I am going to invite to present this topic by Dr. Sandeep Agarwal. Sandeep Agarwal is head of the Department of Critical Care Medicine at Terna Specialty Hospital, Mumbai, and he has many textbooks to his credit, particularly the author of textbook MCQs in Critical Care and author of the book Clinical Cases in Critical Care. He also a teacher in for the Indian Diploma in Critical Care Medicine. He has been invited as faculty in many conferences. He himself organized a lot of conferences, and he's a co-founder and director of one like East Life Healthcare and Advanced Critical Care courses he has designed for the nurses. So with so immense background and all his interest, so I'd like to invite Dr. Sandeep to present this very illustrative topic, and hope this will be a very interesting and interactive session. Dr. Sandeep holds a very key interest in ARDS and mechanical ventilation and focus also. So let's listen from him. What are the very important steps for this oxygen therapy in the ICU, particularly for the nurses? Welcome, Dr. Sandeep. Yeah.
Thank you so much, Dr. Gunadhar. Deepa, can we have my slides, please? Okay. So I welcome all the nurses. So this is one topic which is very important for all of us. So most of the patients who are admitted to hospital and particularly in ICU, many of them do require oxygen. So that is the importance of this topic, that how and what is the best way to deliver oxygen to the patients. Whatever devices we are using, how they are, delivering oxygen to the patients, how the oxygen is being transported in the system, and how do we monitor the oxygen therapy. So for the beginning, let us first go through simple basic pathophysiology of how do oxygen travel throughout the body, right? So oxygen is carried by the blood, correct? So this is carried primarily by two things, which is one is by hemoglobin, which is the primary carrier of oxygen, and all the oxygen that is being delivered to the patient or by the natural route is primarily carried by hemoglobin. So almost 98% of total oxygen is transported in the blood by hemoglobin, and only 2% is directly dissolved in plasma, right? So what is hemoglobin? Hemoglobin is a metalloprotein. So one part is iron, which is heme. Second part is globin, which is a polypeptide chain. So each hemoglobin molecule is subunit has each subunit. Yes. Lost the screen.
Oh, the slides are not moving, Dr. Sandeep?
I cannot see them. Now I can see it.
Sir, please inform me to change the slides.
वो नॉर्मल मीटिंग्स के लिए परेशान नहीं करेंगे
Hello.
Yes, sir.
Hello.
Yes, sir. Please accept the panelist link.
Okay.
Yes, you can start.
Okay. Yeah, I can start. Sorry for this interruption. Okay. Can we go to the previous slide, please? Okay. So I was saying that each hemoglobin molecule is made of one heme moiety, which is an element or iron moiety, and then it is joined by a globin, which is polypeptide chain. Each molecule of hemoglobin can carry 4 units of. So each hemoglobin molecule has 4 subunits, right? And one molecule of oxygen can bind to one subunit of this hemoglobin. So next slide, please. So this is one small figure which tells you how the oxygen moves throughout the body. So if you can see on top, in a dry air which is at normal atmospheric pressure, the air that we are breathing, it contains PO2 of 160 millimeter of mercury. When it reaches your alveoli, the partial pressure of oxygen drops to 100 millimeter of mercury. Then it is carried similar concentration in the arterial oxygen through the left ventricle. Then it reaches to the tissue where there is a gas exchange between tissues and the capillary flow. Here, the PO2 or oxygen transfers from the arterial capillary blood to the tissues, and carbon dioxide is carried in the venous capillary blood. So the oxygen concentration from 160 drops to around 100, and in the venous blood, it drops to around 40 millimeter of mercury, which is carried to the right ventricle and then to the lung, where it is again oxygenated by the oxygen in the alveoli. Next slide, please. Okay. Now, before starting oxygen therapy, we should be able to measure the oxygen in the blood. So oxygen is measured in the blood in primarily 3 ways. One is the partial pressure of dissolved oxygen. So dissolved oxygen is obtained from the ABG measurement. So if you see an ABG, you see a value of PaO2. So there are 3 things that you see. One is PaO2, second is SaO2, and third you can see on your monitor is SpO2. All 3 ways are right in monitoring the oxygen level in the blood. But how do we interpret it is a different way, right? So the partial pressure of SpO2, SaO2, and the PaO2. So what you see in ABG is PaO2, which is the amount of dissolved oxygen, the partial pressure of dissolved oxygen in the plasma. Second is how much of oxygen is hemoglobin is saturated because of all those oxygen is called SaO2, which is again seen in the ABG. Third thing that you continuously monitor on the monitor is oxygen concentration in the form of SpO2, which is a pulse oximeter derived oxygen, which is non-invasive and it can be continuously monitored, and that is why it is also an important way to monitor oxygen levels in the body. Next slide, please. Now, before starting oxygen therapy, let us go through briefly around the indications for starting oxygen therapy. Now, there are some clear-cut, strong indications about starting oxygen, and then there can be few indications where you may or may not want to start oxygen therapy. So one is decreased cardiac performance. So it means that there is heart dysfunction. Patient may be presenting to you in pulmonary edema, and patient might be finding it difficult to breathe, and oxygen saturation may be low. In those kind of situations, you can start oxygen to the patient. Second indication can be increased metabolic need of oxygen. So if the patient is having high-grade fever, chills, rigors, then the body's consumption of oxygen increases. In those situations, you may or may not need to add oxygen therapy to the patients. Some patients present with decreased level of consciousness. So in those patients, the breathing can be erratic. You may find patients, if you have continuously monitored them, you may have a period of low oxygen, then normal saturation, then low saturation. In those kind of situations also, you can start it. Acute shortness of breath, for any reason, if you find a patient who is severely dyspneic, you do not know why they are dyspneic, you can at least start them on oxygen saturation. One very obvious reason is decreased saturation. So there definitely you will start oxygen therapy. I told you about PaO2. So if you see a ABG and hemoglobin saturation, if it is below 60 or saturation is below 90%, then you can definitely start oxygen therapy. You can also think of starting it when there is normal PO2 and SO2, but there are signs and symptoms of significant hypoxemia, which are peripheral hypoxemia. Patient may be confused just because of no other reason. So till you find out a reason, you can start them on oxygen therapy. Patients who have myocardial infarction with the saturation is less than 94%. Next slide, please. Other indications are carbon monoxide poisoning, methemoglobinemia. In all these diseases, the hemoglobin is oxidized and cannot carry oxygen. So the capacity of hemoglobin to carry oxygen decreases, and that is why total delivery of oxygen to the tissue is decreased. So what you want to do is you want to increase the oxygen, which in some cases may displace the abnormal forms with oxygen, and the plasma carrying capacity will be increased so that you will be able to deliver more amount of oxygen to the tissues. Severe anemias, cardiopulmonary arrest, and in patients who have hypotension, cyanosis, chest pain, some other kind of neurological dysfunction, you can definitely think of starting oxygen therapy. In some situations, like very stressful procedures, specifically in high-risk patients, such as you are going to do some endotracheal suctioning, bronchoscopy, thoracentesis, where there are chances that you are going to give them sedatives, analgesics, some kind of anesthesia for them, for prevention of hypoxemia, you can start oxygen therapy. Next, please. Okay. So now you have decided that you want to give oxygen. Now oxygen can be delivered by so many devices. All of you must have used many devices. So now which devices are right for that particular patient or that particular indication, right? That is something that we are going to see. So one of the methods is by blow by, nasal cannula, simple face mask, small diffusers, partial or non-rebreathing masks, hoods, tents, self-inflating ventilation bag, and flow-inflating ventilation bag. We will see in details about all these devices. Next, please. So this is example of something called blow-by device. So if you can see this smallish photo, you can see that you can apply this small oxygen port around the nose of the patient. So most of the times, all these small children who are scared, who feel claustrophobic, or who are not allowing you to put any kind of mask or cannula on their face, here you can put a oxygen opening port, and the oxygen will flow to the patient in a very diluted form. Because the nose and mouth are not covered, the percentage of oxygen delivered will be less, and usually it is less than 30%. So there is no way to find out how much oxygen you are delivering, but it will be less. Right. So the flow rate usually we keep around 10 liters per minute, because there are no specific reservoirs around the mask, but you can use some simple mask or styrofoam or some other kind of thing where you can insert your tube and keep it around the nose and mouth of the patient. Next, please. Second is nasal cannula. All of you must have used nasal cannulas. So all these nasal cannulas are low flow oxygen devices which are used to give oxygen support in patients who are breathing spontaneously. So if you can see the lower right side of the diagram, you can see that in room air, the amount of oxygen that is delivered is 21%. And as you increase oxygen flow through a nasal cannula by 1 liter, the oxygen delivery or the fractional inspiration concentration or FiO2 increases by 4 to 5%. So the maximum that you can give is around 40%, and with 1 liter of oxygen, you can give around 24 to 25% of FiO2 to these patients. So we should limit the flow rate through cannula to say 4-5 liters maximum, not beyond that. Okay, so that would cause discomfort to the patient, nasal crusting, and sometimes causes headache. And beyond that, even if you increase the oxygen flow, it is not going to increase your FiO2 significantly. So there is no point in increasing the oxygen flow from nasal cannula before 4-5 liters. Next, please. Now, second is simple face masks. All of you have seen simple face masks. So this is a face mask which is covering the nose and mouth of the patient. Whatever oxygen, whatever patient breathes is through this face mask. Now, there is small amount of air which is pure oxygen. So you are delivering some oxygen into the face mask. The rest of the tidal volume will come from the atmospheric air, right? So this device can provide oxygen up to 50% of FiO2. Again, this is a low flow oxygen delivery system. And the important thing that you have to ensure while using all these masks are that you strap it properly to the patient. If there are leaks, if the strapping is not good, then the FiO2 that you are giving to the patient will decrease. So if you can see that green strap, so that has to be stretched and it should be connected to the applied to the face properly. You can also see a metal piece over the nose. So you should apply this and gently clip this metal piece over the nose for a better fit. Next, please. Second important device for oxygen delivery is Venturi mask. Okay, so Venturi masks, all of you must have seen, I'm sure. They come in various colors and color coding systems. You can see many color coded Venturi systems. Can anyone tell me how Venturi works? What is the principle on which Venturi works? You can write down on comments. Okay, so Venturi system is used to deliver oxygen up to 60%. It comes in multiple colors. So flow rate of oxygen that you want to give through these devices vary with the particular Venturi system. So for example, if you are using a blue one, then you can use 2 to 4 liters of oxygen per minute, and the final delivery of FiO2 would be around 24%. And this is the lowest one, and the highest one would be through the green system, where you can achieve FiO2 of up to 60% by the use of higher flow of oxygen. So the Venturi, which is color coded, is something that you need to choose, and according to that, there are flow of oxygen in liters. All that flow is also written on the Venturi mask also. So if you see on these color coded small devices, you will see the amount of oxygen that has to be delivered through this which is printed on these things. Now, what is the use of Venturi mask? Why do we want to use Venturi mask? We can use simple face mask also. So Venturi face mask is a fixed flow device system, right? So this system is independent of the patient's respiratory rate and tidal volume. In the simple face mask, what FiO2 you are delivering will depend on the patient's tidal volume, respiratory rate, and fit, which are not in our hands. But in this Venturi, the exact FiO2 that you are delivering to the patient is fixed. So whether the patient is breathing at a respiratory rate of 12 or 20, the FiO2 delivered to those kind of patients will be same. Now, this is the property which makes it very, very useful for use in patients of COPD, where we want the patients to have fixed FiO2. We do not want to over oxygenate the patient. So, which is the principle where we use, which is used in Venturi mask? Next slide, please. It is called Bernoulli's principle. What is Bernoulli's principle? If you can see the image on the right side, the principle says if there is a flow of oxygen in this particular case through a small orifice, it will cause the entrainment of air from the sides, or it will cause a pressure drop where the air will come from the sides. So if you see you can again go back and see in your ICU the Venturi device again. So you will find that there is a small opening where you are fixing the oxygen port, and then there are holes around it, which is used to entrain the air. So there will be 100% oxygen which is going through that particular hole, and it will also sort of suck in or attract the air from the sides. So 100% oxygen plus air will mix in a specified manner, and it will give a fixed FiO2. You can see and check that. Next slide, please. Now, non-rebreathing mask. I'm sure all of you must have seen non-rebreathing mask. If you see the picture on the right side, you can see there is a large reservoir bag which is attached to the mask. Now, what does this reservoir bag does? So all the oxygen that you are delivering to the patient gets collected in this bag, and whatever patient breathes is through this bag. The rest of the expired air comes out through the side ports. So there is no rebreathing. All the air that the patient is breathing is through this reservoir bag, which is 100% full by 100% oxygen. So if you are using it properly, you can deliver near to 90%, 90-95% of FiO2 through these devices. So these devices are used in the patients where there is need of oxygen, which is very high. Most of the times in viral pneumonias, bacterial pneumonias, where rest of the things are okay, but the oxygen requirement is very high. So all these devices can be used to deliver very high FiO2, right? And make sure that you fit that device properly. The fixing system is same as the simple face mask, where you have a nose clip, which is metallic nose clip, and the greenish straps, which you should pull and fix the mask properly to the face. Next. Another one is hood. So you can see this. If you have seen in pediatric patients, because sometimes it becomes difficult to put all those kind of masks and different kind of things over the very small babies. So you can put a hood which is placed on whole of the head of the patient, which is open from the lower end. Oxygen is connected, and the patient breathes in a higher oxygen concentration environment. So what kind of oxygen can be delivered? It is highly variable. It can be 30 to 90%. Should be majority of the times it is used in very, very small babies, and it can sometimes be noisy because of the flow of oxygen through these hoods. Next. Next, please. Similarly, there are tents. Okay. So tents are slightly bigger things. The principle is same. Whole of the patient's environment is filled up with oxygen so that there is a higher amount of FiO2 you can be delivered to the patient. Some of the air goes in and dilutes the 100% oxygen, but the FiO2 that you are going to use will be higher. The amount of oxygen that it can deliver is 25 to 50%. And because it is enclosed system, sometimes the monitoring becomes difficult. There can be a mist accumulation inside the tent, and it can again be noisy, similarly to goods. Next. Okay, so what is this device? The commonly called ambu bag. Correct. Now, the correct name for this device, because multiple companies are making it, it is called self-inflating ventilation bag. What do we mean by self-inflating? Self-inflating means if we compress it, the bag is going to inflate on its own without any other thing. So whether you are giving it oxygen is connected or not, or any air system is connected, inflate on its own. The non-inflating can deliver oxygen, and you can also ventilate the patient, right? So oxygen that you can deliver to the patient by this device is near 100% if you are using a reservoir. If you see this device properly, in the front end, you can see a mask which is connected through a expiratory port and a peephole to the bag. And then on the back side of the bag, there is a large reservoir bag. Okay, this greenish tubing is oxygen tubing. So all the oxygen that you are connecting goes through the reservoir bag and the inflating bag. So there are valves on the back side also and on the front side also, which ensure that the delivery of air and oxygen is in the one direction only, which is in the forward direction. So if you are using that reservoir bag, you can give almost up to 100% of oxygen to the patients. And you can also provide ventilation through this system. Next, please. Okay, so this is slow inflating ventilation bag. Can you now see these greenish bags? Can you ventilate with this bag without oxygen? So if your oxygen tubing is not connected to the oxygen system, can you ventilate the patient now? You cannot, because this bag is not going to inflate on its own. And that is the importance of using self-inflating bag. At least with self-inflating bag, you will be able to ventilate and at least going to give, without even oxygen, you can give at least 21% of oxygen. With this collapsing bag, which is dependent on oxygen or airflow for ventilation, you cannot do anything, right? So that self-inflating bag system is very, very important. Now, when you are using this flow inflating ventilation bag, you must ensure that your oxygen delivery is proper. Whether you are using it is in for transport, for OT, or for any other place, oxygen has to be there with you always. So this system can also deliver 100% oxygen, right? And it can also ventilate apart from giving oxygenation. And it needs a bit of experience to use this system, and that non-inflating bag is very easy to use. Next, please. Now, Bain circuit is a kind of non-self-inflating system. Again, you have a bag which is going to reserve the bag which you need to ventilate, which collapses in the absence of oxygen. So it is primarily used as anesthesia delivery system, and in ICU, most of the times it is used to transport the patients. Right? Again, the mechanism is same. there are two tubings. This greenish tubing is inside another tubing, which is a corrugated tubing. And the oxygen flow goes through this inside tubing, goes to the patient, and the expiratory gases are contained back to the outside tubing. And if you can see expiratory valve near your bag, if you can see a smallish expiratory valve, so all the expired gases are ventilated through this smallish expiratory valve to the atmospheric air. Okay, next please. Okay, so this is from my side. I also have made few MCQs at the end. So let us take us questions first, please.
Yeah, I think that's better. So Dr. Sandeep has brilliantly explained all the simple devices, and our nurses should able to handle it properly. And you know, the oxygen therapy is very, very important part. So it depends on the patient clinical condition. Okay, and oxygen is now considered to be a drug actually. So like how you give medications like antibiotic and other drugs, you should also be careful while giving oxygen, because oxygen is not good all the times, but simultaneously you should not also deprive the patient when the patient actually needs oxygen, like patients in respiratory failure and the patient is hypoxic and the patient is actually need oxygen, you have to give it. But excessive oxygen is also sometimes very bad. It can cause pulmonary toxicity and it can cause other toxicities. It can cause a lot of inflammation. So that is the reason now if the saturation is more than 94-95% on the room air, patient is comfortable. Not all the times you have to give the oxygen actually. So there are a few questions, Dr. Sandeep. So why we should not give more oxygen in type 2 respiratory failure patients? You would like to take it?
Yeah, why not? So that is actually one of the MCQs. Anyways, we can answer it, or maybe I can answer it in the same MCQ.
Yeah, I think that's better. Yeah.
So that would be better. Any more question?
I think I'm not finding any questions here, but of course there are a lot of delegates so who want to listen and participate. So if you can like just go to the MCQ so that you know it will be better for us to discuss.
Okay. Okay. So this is the first question. Which of the following oxygen delivery devices provides the highest concentration of oxygen?
Yeah.
We can have answers.
Yeah, can you put all your options in the chat box? Yeah. So
One answer. Okay.
yeah, somebody has.
Somebody.
Yeah.
Okay. So one answer is C, one answer is D. Okay. Any more?
So majority of them are like saying it is D actually till now.
Right.
So let's see what is the right choice.
Next slide. So the answer is C, previous one. Yeah. So the answer is C, non-rebreathing mask. Okay, Venturi mask can give you a FiO2 of a maximum of 60%. With non-rebreathing mask, you can achieve oxygen concentration close to 100% even. So 90, 95, 100% oxygen concentration can be achieved by using non-rebreather mask, and maximum you can use by Venturi is around 60%.
So the Venturi, I just would like to one comment here. The Venturi, what Dr. Sandeep told, basically it's a mode of controlled oxygen therapy. See, suppose you want to give different FiO2 to different patients. A patient who is on COPD and he may not tolerate a very high FiO2 and high oxygen concentration, you want to restrict the oxygen concentration as per your own wish, then in that case you have to use the Venturi. So the Venturi, as Dr. Sandeep has shown in the picture, right, different color coded and a different flow of oxygen. If you attach different Venturi, then it will give you some fixed percentage starting from 24% to almost 60%. So that is the advantage of the Venturi actually. So this is the method of controlled oxygen therapy. But here the non-rebreather mask is a mask where actually if the flow requirement is very high, if you give a flow of almost around 10 to 12 liters, and if the bag is full, sometimes you may give almost up to a range of 100%, 99 to 100%. But the only disadvantage is that when the patient breathes such a high oxygen from a non-rebreather mask, sometimes what happens, if the patient is actually tachypnic because of many reasons, and when you supply a very high concentration of oxygen, so sometimes this may misguide you that the patient is actually settling down and the oxygenation is better, but the underlying cause may not always be, corrected. So that is the reason whenever you, and lot of patients, if the valve is not functioning properly or if they don't use it properly, then there is always a chance of carbon dioxide retention. That is another issue. So the CO2 retention is always an issue. You have to always look for the CO2 retention in such patient when you give a very high concentration of oxygen. And that is the reason when you give the patient this non-rebreathing mask, you should absolutely be beside the patient, standing beside the patient and monitoring the things. And as far as possible, you should try to avoid giving 100% oxygen, unless until it is a dire life-saving things where you really want to give 100% oxygen. I think, hope I'm clear, or anything from your side, Dr. Sandeep, like to say?
So oxygen concentration. So the question was on oxygen concentration. So the concentration which is maximum is delivered by this particular system, which we commonly called an RBM. I think almost all of you must have used it. Venturi system, the primary use of Venturi system is to give a controlled or fixed flow of oxygen, fixed FiO2 of oxygen, and not to give very high concentration. That is not the whole idea about it. So whatever the patient is breathing in, if it is majority of it is going to be 100% oxygen, then the FiO2 is going to be high. And rest of the system, say for example, nasal prongs or simple face mask, this oxygen which you are giving from externally, which is 100% oxygen, is diluted by air, because the tidal volume is not going to be satisfied by 3, 4, 5 liters of oxygen. So rest of the air which is coming from atmosphere is going to be 21%. So that is going to give you a lesser and lesser amount of FiO2, final FiO2. But in NRBM, the patient is breathing from that big mask, which is a reservoir bag, which is filled up with 100% oxygen. So FiO2 is going to be very high in that particular NRBM mask. Okay, let us go to the next one. Okay, so this I have not shown you, but let us see indications for high flow nasal cannula, and which is most appropriate for which of the following patients: patients with mild hypoxemia on room air, patients with severe ARDS requiring intubation, patient who has moderate hypoxemia and respiratory distress, or patient with stable COPD on oxygen home therapy. Okay, one answer. Somebody wants to say B. Why not B? Okay. So high flow nasal cannula system is entirely different from simple nasal cannula. Okay, it is used again to deliver fixed amount of oxygen flow. It also increases, it also gives a little bit of PEEP. So apart from oxygen, it gives a little bit of PEEP. And in patients who are requiring moderate hypoxemia, who have moderate hypoxemia, this is a very, very good device. But the one contraindication is type 2 respiratory failure. So the patient should have type 1 respiratory failure, which means the carbon dioxide should be in the normal range or very mild elevation is acceptable. Now, in all these options, option 1 is patient with mild hypoxemia. So we do not need to use HFNC in mild hypoxemia where saturation is already 95%. Option B is severe ARDS. So HFNC use in ARDS is gaining traction. So many patients of ARDS or type 1 respiratory failure are being put on HFNC, but not in severe ARDS where the intubation is indicated. So in those patients, we should go for intubation and not for HFNC, right? Third, D, somebody has answered D, a patient with stable COPD on home oxygen therapy. Again, we have discussed that all those COPD patients need titrated or fixed flow oxygen delivery system, and probably in a stable COPD, we can get away with a Venturi mask. We do not need high flow nasal cannula. So the best answer would be a patient with moderate hypoxemia and respiratory distress. Next, please.
Yeah, so next time when you go and see the how does the high flow nasal cannula looks like. So this is basically just a device, just like how you give the NIV, non-invasive ventilation. It is a similar device, but there is a nasal cannula and there is a circuit through which you can give a very high flow oxygen up to a flow of 60 liters. So minimum from 10 to 20 liters, 20 liters to 60 liters you can give, but the patient do not feel any discomfort, unlike the NIV where the patient sometimes uh, sometimes the patient may not tolerate the NIV well, but HFNC is very comfortable actually. Okay, so that is the advantage of HFNC, but and simultaneously you can give a very high
Next. Next. Okay. So this question is regarding oxygen toxicity. So prolonged exposure to high concentration of oxygen can lead to which complications? Metabolic alkalosis, absorptive atelectasis, increase in cardiac output, or hypercapnic respiratory failure in. So this is a general question. In a general population. In a general population, I'm saying.
This is a very good question actually. It's a very good question and you have to think before answering this. Okay. And
I'm giving a
very
hint that
important.
it is a general population, not all the patients.
So majority of them have gone for the D till now.
Yes. Good. Can we go to the answer, please? The answer is absorptive atelectasis. So not all the patients in a general population where you are giving high oxygen for a prolonged period of time, not all of them are going to go in a type 2 respiratory failure, right? That phenomena is specifically for COPD patients. Okay, even not in all the type 2 respiratory failure patients, specifically to majority of them are COPD patients. So do not, so why I have kept it is because that is one that looks very, very obvious answer. So do not go for very, very obvious answer. Look for question, see what exactly the question is about, and then go for it. Okay. Next question. Okay. Now, I think we are going to COPD where everybody is comfortable, I think. So what is the recommended oxygen saturation target for COPD patients receiving oxygen therapy? Now, this should be easy to answer. Mhm. Mhm. Okay.
Majority is A.
Yes. Can we see the answer? We will answer you in detail in the next question. Why it is so. Okay. Can we go to the answer? So answer is A, which is 88 to 92%. A patient of COPD in type 2 failure should be given a titrated oxygen therapy to target a saturation of say around 88 to 92%. Not less than this, because that will cause hypoxemia and that is going to be detrimental. Higher amount of oxygen and higher saturations will also be detrimental because of oxygen induced hypercapnia. I will tell you why it happens. Next question. Okay. So which of the following is an indication for invasive mechanical ventilation in patient receiving oxygen therapy? So this patient is, you are already giving oxygen therapy to one patient. Now, which of these patients should go on invasive mechanical ventilation? So that is the question. A patient who has a PO2 of 80%, 80 mmHg on room air, patient has saturation of 94% on nasal cannula, persistent acidosis with hypercapnia, and mild tachypnea with normal blood gases. Okay,
So
good.
majority of the choice are C.
I think this is an easy one.
This is I think most of them are right.
Yeah. Let us go to the last one. Next. So now, why is Venturi mask preferred for patients with COPD? It delivers high concentration. It provides precise and controlled oxygen concentration. It is the most comfortable device, or it humidifies the oxygen effectively, which should be the best answer.
I think this we have discussed. This should not be any mistake.
Okay. Anyone else?
So B and C, between B and C, yeah, majority is B.
C. Okay. Okay. You want to answer, Dr. Gunadhar?
Yeah, I think we have just discussed this. So it's very important that you need to understand. I think those who have answered about C, they need to understand that it is not about the comfort. Actually, the thing is that it is the most important way to control the oxygen therapy in a patient of COPD or where you don't want to give them very high concentration of oxygen. There, actually, the Venturi is a very important tool. So Venturi is a device which is actually delivers the oxygen concentration in a very precise and controlled manner. So like if I want to give somebody 24% oxygen FiO2, 40% FiO2 or 60% FiO2. So those cases I can adjust my FiO2 as per the different choice of the Venturi. So this is the most important concept of the Venturi mask. Okay.
So I think we have discussed it
Yeah.
in the previous MCQs also, that the primary reason of using Venturi mask for oxygen delivery is that you can give a very fixed flow of oxygen, fixed FiO2 of oxygen, where it will not be dependent on the patient's respiratory rate, tidal volume, and whatever. So the only reason you want to use venturi mask is to give fixed FiO2. Correct. Now the first question was why we want to give fixed FiO2, why not high FiO2? So another question was why you want to keep saturation between 88 to 92%. What if we give it higher? Okay. So many of you know that if you give a higher concentration of oxygen or the saturations are kept high in COPD patients who present with type 2 respiratory failure, the higher delivery of oxygen is going to lead to hypercapnia. The oxygen, the carbon dioxide in patient will increase further. Now, why does that happen? So there are at least 2-3 ways, right? One of the important ways is uh, something called the patients of COPD are majority of the times are always having higher CO2, right? So their normal CO2 levels are going to be say 45, 50, 55. They are used to very high levels of CO2, higher than normal. If you give them lower amount of oxygen, the concentration or saturation is lower, that triggers their brain. So the hypoxia triggers the respiratory system, not the hypercarbia. Normally, if carbon dioxide increases, it increases the respiratory trigger for improved ventilation and respiratory rate. Now, if that system is hampered, the next system that works is hypoxemia. So if the patient, if the body triggers hypoxemia, that increases the respiratory rate and tidal volume in the patient and the ventilation improves. But if you give high amount of oxygen, that trigger is also gone. So hypoxia trigger is also gone. So that would lead to, again, lesser ventilation. So that is a small mechanism by which it causes hypercarbia. The bigger mechanism is something called Haldane effect. Does anyone know about Haldane effect? Okay. So the Haldane effect is that hypoxia, if the when the in the second slide I showed you that there is a blood flow where PO2 and CO2 reaches the tissue, where oxygen is delivered to tissue and carbon dioxide is picked up from the tissue into the blood, right? The Haldane effect is if your oxygen level at the tissue is very high, say suppose normally the PO2 at tissue level is around 40, it increases to 50 because you have delivered higher amount of oxygen to the patient. Then it will hamper the take up of carbon dioxide from the tissues. So Haldane effect means, you can go and read about it in detail if you are not able to understand what I'm saying. It says that the affinity of CO2 to hemoglobin decreases in hyperoxic state, which means if the blood has higher amount of oxygen, the carbon dioxide will not be carried in the blood effectively, which means that carbon dioxide at tissue level will be left at the tissue level and it will not be taken up. So it will be dissolved in plasma and the plasma levels are going to be increased. So that is called Haldane effect. So these two or 2-3 mechanisms are important for the titrated oxygen therapy to the COPD patients with type 2 failure, not all. Okay, so the
More
answer
questions
can
are there?
show last one. This is the last one.
Okay, okay.
Can we show the answer also? So this is the answer. So we are not talking about comfort of the patients. Comfort would be a different, particularly going to be very, very specific. From my side, this is the end of the presentation.
Yeah, I think you have covered almost everything, and also the MCQs, which is actually very like throw some lights on the core knowledge. So I think it's one of the very good session, and almost everything has been covered. So what is more important is that they should go and see the every individual device, and they should know the utility, how to use it. Then the use will be more and more precise. I think that is the most important key. So I request all the delegates who are here, just go and see how the device is being operated, like particularly the high flow nasal cannula, the NIV, the NRBM. Of course, you must have handled almost all of them. Nowadays, very few centers are having this Venturi actually, but you just go and see how the Venturi works. Like Dr. Sandeep has discussed regarding the Venturi principle. Okay, so all these things are very small, but those are very important things. And oxygen is a basic, I think, drug which is to be given in the ICU. So nobody should be deprived of oxygen if it is indicated. So that is the motto of this whole lecture. So the important thing is that you should be familiar with all these newer gadgets, particularly the HFNC and all. And sometimes you may need to operate it with the proper instruction and all. If you don't operate it properly, sometimes your oxygen may not go to the patient, and you think that actually you are giving the oxygen, but actually patient is not getting anything. Like that famous quote, how you say that every night there was a death in the ICU. In one ICU, every night there was a death because the sweeper, which is just cleaning the ventilator, actually is disconnecting the oxygen port from the patient and cleaned it. So these are the very small point, but you see how important those are actually. So with that background, I think we'd like to come to the end of this lecture. And if any questions, we are happy to take, or otherwise we'll just like to wind up the lecture sessions today, and hope to see you soon in the more and more lectures to come. And again, thanks to Dr. Sandeep for the illustrative description about the oxygen therapy.
Oh, okay. We have any more questions?
No, I don't think that any questions are there.
We can conclude this now then, maybe?
Yeah, I think.
Thank you, Dr. Gunadhar, and thank you, ICC.
Yeah, thank you, ICCM, for this